Thank you all for tuning in. Really excited to be speaking with Dr. Sharon Hausman Cohen, and of course to have Deepthi on with me again this week. Sharon is a real expert in genetics. She's a Harvard-trained physician, and she's the co-founder of a company called Intellex DNA, which is one of the most thoughtful companies, as far as I'm concerned, as it relates to genetic testing and how to incorporate it into practice. And so I think to set the stage, as I've shared in some of the posts I've done about this, I think there are a lot of questions that people have about how to use genetic testing in medicine generally, but especially in the practice of what we call longevity medicine, personalized medicine. And so Sharon has a wealth of experience, probably more than almost anyone that I know, using these tests in the context of clinical practice, and not just using them as ways to get information and satisfy curiosity, but actually to change health and to improve outcomes. And so I'm excited to have her on. Sharon, looking forward to the conversation today. I guess to start, like, anything you want to add about your background, and otherwise would love to have you just kind of launch into, if you can, like your thoughts on how should clinicians be thinking about genetic testing as it relates to personalized medicine?
Yeah, I think that let's just jump into the topic since we have limited time. And you mentioned the topic of longevity, and we said we would talk about longevity. So I think let's talk about personalized medicine with regards to longevity to start with, because you'll see that that relates to everything else. So when a patient comes to any of us and says, I want you to optimize my longevity, they're not really saying, I want you to optimize how many years I am on this planet. What they're really saying is, I want you to optimize my healthy aging and my healthy longevity. And so a lot of times people have read books and maybe they're doing resveratrol and things for their, longevity pathways, metformin that they've read. But when I look at someone with longevity, I need to know what are their threats to healthy longevity. Because if you have macular degeneration and blindness, that affects your longevity. If you have problems with cognition and dementia, you might be alive, but if you can't think clearly, obviously that affects your healthy longevity. And then the classic things like your cardiac status, of course, that's longevity. But even osteoporosis, somebody's pinging in the background, even osteoporosis can affect your longevity, because if you're hunched over, you can't get on a plane. If you're using a walker, it's going to again affect your health. So the first thing to think about with precision medicine is when somebody does Intellex DNA to optimize longevity, we're going to have them get information about all of these different things. They're also going to have information about inflammation and oxidative stress. Oxidative stress is really important for cancer risk reduction for people who are not, who have cancer in their families, but don't have a cancer gene. A lot of it is because they can't remove toxins. So all of that is important. Then the next really thing that's unique about Intellex DNA is it was built by integrative and functional medicine trained physicians for integrative and functional medicine practitioners. And so you don't want to just have all this information like, oh gosh, you've got all these genes that contribute to cognitive decline. Too bad for you. But there's very, very specific interventions for each of the gene variants based on how the gene works and how the gene variant works. So how your mitochondria, which are like energy source in your brain, works can really affect cognition. It can almost triple your risk if you have problems with this. Well, there are specific different things you can do, like plasmalogens and mitochondrial membrane support for people with that. But if your problem with your brain has to do with really high inflammation because of something called TNF alpha, then lion's mane mushroom might be a better option for you. And if you can't transport B12 into your brain, then B12 is going to be really important. And so Intellex DNA helps our longevity physicians make a map specific for the patient on how to optimize their health and wellness, which is longevity.
So Sharon, thanks for that explanation. And I think this is a big topic, and it's fairly complicated too, I think, on a lot of levels. So let's start with, there's a few different angles to this. So one of your core theses is that chronic disease is rarely about a gene, a single gene. It's usually many variants, as you just described, interacting with each other, interacting with someone's lifestyle and the environment. So can you give us a concrete example where there's two variants that might come up for people that look unremarkable, but then when they're together, they become more important or clinically relevant?
Sure. There's tons of gene combinations that can interact. I think that one example, because in the longevity world, most doctors think a lot about hormones. And so there are different kinds of estrogen receptors, but there's these estrogen receptors that make you have all the proestrogenic effects. And so when you're younger, if you have overactive, we're going to call them ESR1, or they also are called ESR alpha, you're going to have more of that estrogen dominance type stuff. You might have fibroids, you might get more breast tenderness, all kinds of things like that, even more endometriosis. But when there's another estrogen receptor variant, ESR2, that dampens the effects of ESR1. When you have, and it's meant to kind of, because we have to have modulation, checks and balances. Now, in the absence of estrogen, when you're postmenopausal, or men when their testosterone levels get low because testosterone gets converted to estrogen for men, you get a whole different set of effects with these estrogen receptors. They can turn on all this inflammation, and ESR2 is supposed to turn it off. So if you have the combination, this not so great combination of high ESR1 and low ESR2, which is all because of genetic variants, that combination of grouping of SNPs can give you, even as a guy, 3 times the risk of cognitive decline if you don't keep your testosterone and estrogen levels high, or as a woman, your estrogen levels high. So for those women, I have a patient who has that combination. She is in her 70s. We still have her on hormones, which some traditional doctors might say, oh, you shouldn't be having someone on a hormone replacement. I mean, we're actually using pellets, not oral. I would not do oral in a senior, but you wouldn't normally in the conventional world, they'd say you should stop that when somebody reaches their, 60 for sure. Well, for her cognition we've been measuring it with tools, is so much better now because we knew that about her and we keep her on it. There's other gene variants that can be hidden as well. Another example is a patient who came to me with heart disease, and he had his first heart attack at 61. He had seen a cardiologist before he came to me, and he didn't have high blood pressure. He didn't have high blood sugar. His hemoglobin A1C was like 5.4. He didn't have high cholesterol, maybe a little high, like an LDL in the 120s, 130s, but he had a heart attack. And so something was going on. And when we looked at his genomics, he had a lot of hidden risk factors. He had something called GCLC, and don't worry about the alphabet soup. If you want to use genomics in your practice, or you're a patient and you use it, you need to use an interpreted tool. And that's what Intellex DNA is. But this makes it so you can't make glutathione. Now, glutathione is what's called an antioxidant. It gets rid of your toxins, your stress. And we just make these just from breathing. Oxygen becomes superoxide over time. I mean, you get degradation of different products in our body create oxidative stress. You get waste products. So he couldn't make glutathione, which was a really important antioxidant, but he also couldn't make CoQ10. He also couldn't recycle vitamin C. That combination of being unable to kind of keep adequate in antioxidants of his 3 most important antioxidants, glutathione, CoQ10, and vitamin C, was really what led to his heart disease. Just having the GCLC SNP alone can give you more than triple the risk of heart disease. So again, what did his doctor done? His cardiologist put him on high-dose statins. What do high-dose statins do? They add to your oxidative stress because they further deplete CoQ10. So I didn't stop his statins. I wasn't his cardiologist, but at least by giving him something to do to address the underlying root causes, giving him glutathione in a form that can actually raise levels, giving him vitamin C, addressing CoQ10 with high doses, could really make a difference for him.
Super interesting. Yeah, I mean, I think one of the things that's become apparent, and we just had, Dr. Abid Hussein talk to us about cardiology from a systems perspective, is how many of the diseases that we've often thought of, through a very simplistic, like almost monocausal paradigm, are actually so much more multifactorial than we ever could have realized. And I think the systems biology paradigm, I think, is really well illustrated by what you just said. Um, I'm curious, like, just to get your take on this point, right? That there's this belief or idea that's been popular lately about how your genetics are, only 20% of what determines your health outcomes, or something like that. I may not be precise here. And then, as you know, there are also there was actually a study that came out recently that seemed to indicate that maybe it's more genetics determine more. And so I think there's a mixed relationship people have about genetics, where I think there are some people who are like, yeah, genetics, they feel like they're deterministic. So therefore, I like the idea of genetics only being 20% because it makes me feel like I have more under my control. But I'm just curious, like, how do you respond to that, right? If somebody says,
Yeah.
oh, genetics only 20%, so why should I care about this?
And I would say, yes, genetics is only a small piece of the puzzle, but you still have to know it in order to address it, because what we're talking about, what's the other 80%? And I think genetics is more than 20%. I think that the reason that some of those studies have shown such a low percentage is they're looking at classic genes associated with something. So they might look at, like, if you look at the risk calculators, again, for heart disease, for Alzheimer's, for diabetes, they're missing a lot of things that we in the functional medicine world would call fundamentals, things that relate to nutrients, to inflammation, to oxidative stress, to gut. So when you add in all of that, which all of those things interact with environment, I think your genetics is probably at least 50%, but it's not these well-known, very rare pathogenic genes. It's these genes that are common, found in 1%, 5%, 10, even 20 or 30% of the population, that contribute like little building blocks. And so the reason I would say, yes, it's only a piece of the puzzle is because genetics can interact with environment. We saw this in a study in Ecuador. There are these genes that relate, again, to your inability to remove certain toxins, including pesticides and glyphosates. Glyphosates have been in the news lately, which is Roundup. And what they found is the women, they were doing, there's a cocaine grows heavily in Colombia, and Colombia borders Ecuador. So they were spraying the Colombian area where the cocaine was growing to get rid of it. But of course, it traveled across the border, doesn't see the border, traveled into the Ecuadorian airspace where coffee growers were growing their coffee beans.
Mm.
And an epidemiologist studied these people, and they found that the people who had these detox pathways, GPX1 and GTSP1, that were two variants in them so that they couldn't detox well, they had higher risk of obesity for decades afterwards, and they had higher risk of having birth defects in their children or miscarriages because of these detox pathways. So that's a clear example that the effect was magnified by the fact that they were exposed to these really high levels. And we see that people exposed to a lot of pesticides, farmers that are applying pesticides, et cetera, if they have certain genes that can contribute to eye problems, kidney problems, problems with cancer risk, they're going to have a bigger effect. So maybe it would only be a 30% increased risk in the average person, but in them, they had triple the risk, a 200% increased risk. So I definitely think that, yes, your genes are not your destiny, but if you know those things, so if you know that you can't detox pesticides, there's multiple genes involved, but one's PON1. Well, there's things you can do to upregulate your PON1. There's something called ellagic acid. There's urolithin A, which are kind of longevity things that people have often heard of. But even 2 ounces of pomegranate juice a day can upregulate that gene up to 80%. In the mental health world, genomics is super important. And this algorithmic approach has become the norm. Okay, we start with, if someone's depressed, we're going to start with SSRIs, and then we're going to go to SNRIs, and then we'll go to atypicals. But you can have people that are getting depression because of high inflammatory markers. You can have people that are having treatment resistant depression because of their endocannabinoid pathways. I know we have both doctors listening and then people who are just interested in the topic. But a lot of you have heard of like the runner's high and opioids, but there's another pathway that are bliss molecules. They're called endocannabinoid pathways, and it is does interact with the system of where THC or marijuana binds. But if you have problems with these bliss pathways, then SSRIs, Lexapro, citalopram, Zoloft, they're not going to work at all. And instead, you need to be treating with things that address those pathways, which would be things like palmitoyl ethanolamide and omega-3s. And so we have cases. One of my colleagues, who's a psychiatrist in New York, had a patient who was a colleague. She was a physician who had tried to commit suicide 6 times. And this person is now fine because they now understood that they were going about it the wrong way. Their treatment resistant depression is just a label. Their depression is it's no worse than someone whose depression is caused by the inability to make serotonin. It's just different. And so why label it? Oh, you're really bad. You've got treatment resistant depression. No, we were just barking up the wrong tree. And in medicine, we got this idea that if we give 2 people the same diagnosis, so they're both diagnosed with heart disease or depression, like the examples we've given, then we should be able to this is the best treatment. But medicine has to change. And that's what Intellex DNA, my co-founder, and I, the whole reason we made the company is we're labeling people rather than looking at the root cause and trying to get them well. And we now have that technology in medicine. Let's use it.
Yeah. I mean, Sharon, I have to be honest, the more I talk to you, the more I think there's so much that we don't know about how we practice medicine. And part of me leaving, my traditional sort of medicine career was because I feel like we didn't know enough and I wanted to dig deeper. And then when I talk to you, I'm like, man, there's still so much we don't know. But to your point though, mainstream genetics, mainstream medicine has been really skeptical of using these sorts of panels in everyday practice. So when a colleague tells you that the evidence isn't there yet, how are you responding to them?
So what I say is there are a lot of different products out there. And so first of all, you have to know what is the accuracy, what is the evidence, how is the tool built. But every single sentence in Intellex DNA is referenced. So if I say this gene is associated with 2.4 times the risk of premature heart disease, and it causes cardiac calcification to be increased, then those are referenced. They can go check the references. And then the thing that makes genomics actionable, that right now I don't think there's too many tools doing, I can't name another one other than Intellex right now, is that we then had our research team go, okay, so the gene I'm talking about is called CDKN2A, causes calcium to go into the arteries. We then go, well, what does it do? Well, it affects this protein called matrix GLA. Again, don't worry about what it does, that you can directly make it so you have more of this mature form of the protein that blocks the ability for calcium to go into the arteries. So it goes to the bones, not where it's supposed to be, with vitamin K2. Well, that's a reference. You can go look at it. And then we have the reference, vitamin K2 has been shown to decrease cardiac mortality 50%. And so for a doctor to say they don't believe it, the evidence is not there. What I say is, give me 3 of your patients that you don't feel like you've adequately gotten well, or give me any of your patients with the disease. Let's talk about the insights together. Don't judge something without using it. So I think that the barrier has been that there was a lot of genomics that was designed for other purposes. 23andMe and Ancestry were designed so you could go, where are my relatives from? So to try to use that to make clinical decisions when you don't know what each of those variants do and which ones are clinically relevant and what to do about them, it's not going to work. But we have publications. I admit they're still small. They're case series. There's not large cases when we are looking and actively working to be able to do larger case studies, but they're expensive. So right now the publications are still small, but we have publications in autism, in treatment-resistant mental health, in cognitive decline. And so we have thousands of doctors using this that will say to the doctor who is skeptical, look, I can give you a list of patients that I've gotten well. I can give you a list of children that had ATEC scores, autism scores that were in the severe autism that are now in the mild, or that were in the moderate that are now rescued, that don't meet the criteria anymore, because it helps me understand what's going on. Or people with cognitive decline, not everyone. If you have someone who comes to you with dementia and it's already pretty severe dementia, they've had a lot of neurodegeneration, and I would never tell those patients that I can get them well. But when you have someone who has mild cognitive impairment, the first signs of memory loss, even almost bordering dementia, we have publications showing we can get those people many, many times well. So I say to the skeptics, have a conversation with me. Let's try it. And I bet that you'll change your mind. And we have doctors from really well-respected institutions, from Harvard, from Johns Hopkins, from the Cleveland Clinic, and many universities using this. And we even have 2 different universities doing trials right now in the adult with autism world, and or special needs adults. And they're going really well. So again, give us a chance.
Awesome.
Well, go ahead.
I was going to say, I'd love to turn to some questions that have come in. There's some really good questions that people have submitted here. So the first question relates to biomarkers, right? And so, and I think you've kind of touched on this a little bit, but if you could just maybe share some examples of how, knowing the result of a genetic test influences biomarkers that you might measure or monitor.
Absolutely. It's kind of funny because I'll have doctors come up to me. Like I had one come up to me recently, and this patient had problems with a gene called CYP1B1. And for those of you who are in the medical world, that can make it so you don't detox hormones properly, as well as some other chemicals. And so that your estrogen can be going down something called the 4-hydroxy pathway instead of the 2-hydroxy. And doctors will previously have used something called the Dutch test to measure kind of 4-hydroxy to 2-hydroxy levels. And they were like, guess what? My patient who had a Dutch test showing the high 4-hydroxy, they had the CYP1B1. And then when I did the recommendations that you said to slow down that CYP1B1, that all got better. And I was like, yeah, because you're addressing the root cause. It doesn't surprise me. Or somebody who does the urine, some of the different panels, like Mosaic's panel for urine organic acids, and it shows different levels, like really high dopamine. And then they have ADHD, and they have the gene, which can be associated. There's 2 genes that interact. You were asking about that before, Deepti, that can create real problems converting your dopamine into norepinephrine. So you get really high dopamine, you get stuck. And they'll go, you know what? They had that, and 15 times the risk of ADHD on the genomics report, and their urine organic acid showed that. Or urine organic acids can show the problems with inability to recycle vitamin C. So on and on and on. But there's also more. There's a gene that's important in children that affects your immune system. And it's called mannose-binding lectin. And it's highly associated with PANDAS and PANS because you can't fight off a lot of different infections. So it's not just about strep. So it's more every kind of infection. It's spirochetes like Lyme disease. It has to do with viruses, bacteria, but also yeast. Well, when you know that somebody has either one of the more serious copies of this MBL2 or 2 copies of the more minor one, you're going to be thinking about testing their gut microbiome, and you're going to see things off in their gut microbiome because their immune system isn't right. And it tends to get a little bit better as we get older because it's the first part of the immune system that activates when you first see it with complement and such. So we have thousands of examples of how the genomics matches the biomarkers. But the really cool thing is with one cheek swab, you can get, depending on what test you order, 400, 600, 900 pieces of data. That's almost like getting hundreds of biomarkers with one test and just address them. You don't have to go prove it. And I think that it's really important not to get in the mindset of, okay, now this I need to prove, because there's something called differential tissue expression, which means when you do a blood test or a urine test, you're only getting information about the genes expressed in the blood. So, but when I talked about those endocannabinoid receptors in the brain, there aren't any endocannabinoid receptors in the blood. So there's nothing you can tell from the blood that's going to let you know how those are working. And when I talked about transporters of B12 to the brain, those transporters aren't in the blood. They're only in your DNA. Well, actually, you could measure transporters from the blood if you measured the DNA, but you can't measure B12 levels in the blood and tell about B12 levels in the brain, because it's about not being able to transport it across the blood-brain barrier. So I encourage our doctors to start with the genomics, but then use the genomics to make decisions as to what further testing is needed. If there's a lot of immune dysfunction things, you might need stool testing. If there's a lot of pathways that relate to poor detox relating to mercury or to different pesticides, then you might want to check those levels. Or you could just start detoxing them and then see how you do if they're already having symptoms that would fit with those. So it's just a different way of practicing medicine. And one of our doctors told me, she said, even her friends had noticed she had kind of gotten disillusioned with practicing medicine and wasn't happy anymore practicing medicine because there were so many people she didn't feel like she was really getting well. And she goes, now I have joy again in medicine because I feel like I can help so many more people. So it's really fun.
So to your point, Sharon, you were saying that this could be, aside from a lot of the blood biomarker testing that we do and body composition, et cetera, this could be another, almost like a preliminary test to do when people are walking through the door. And most of this is already being done in a cash pay setting. And so how do you address that conversation with the price of the Intellix DNA test? And is that something you foresee coming down in the future? And that's one of our questions from our audience.
So Intellix DNA is more of an investment. You have to pay the doctor to do the Intellix DNA test, but then depending on what test you're ordering, you're talking, $700 to $1,700 if you wanted to do everything just for the testing, not including the doctor's time. So the average person will spend approximately $1,000, $1,200 for just $1,200 is the most common test, is the executive report, all the brain stuff, all the hormones, all the detox, all the inflammation, all the internal medicine stuff from thyroid to hypertension to heart disease to diabetes to obesity and anesthesia metabolism. I know you're an anesthesiologist by training originally. And at first that seems like a big investment, or, around the same price for the autism and pediatric thing. But when you look at the cost, most of the people of going back and forth to a doctor trying to untangle mysteries and ordering this test for $300 and this test for $500 and this test for $200 and trying to piece it together. First of all, it takes a lot longer. So you spend a lot longer with doctors' bills. But it also is really very cost effective. And I'd rather talk about the value and why Intellix is so much more expensive. Intellix DNA is not about just giving you a list of SNPs. You can get a list of SNPs cheap. There's all kinds of, you can go do whole genomic sequencing and get a big list of SNPs. It's about the research that allows you to know that the fundamentals and all things like glutathione, GCLC can relate to heart disease and what to do about it. It's what do you do about endocannabinoids for depression that has evidence in depression, and even the dosing. So as a physician, people sometimes give us more credit. Sometimes they give us less credit due and sometimes more credit due. They'll go, here's this report. Can you help me optimize my cognition? No, if it's not an interpreted report, we can't do that because we don't know the 1 million variants by heart, what they do and how to respond to it. And so Intellix DNA has invested literally millions of dollars into research and development. And what they're paying for is having their physician have a guide and all the references at their fingertips. In terms of what's going to happen in the future, we have been investing in making it easier for the physicians to see the underlying root causes so that when you put in that heart disease, you can literally in a matter of seconds have it pop up and say this variant, this variant, this variant, this variant, including the ones relating to nutrients, oxidative stress, all relate to heart disease. Here's why. Have a discussion. So we're focusing our investment on making Intellix DNA easier to use. That investment is also a huge financial investment on our part. We have a team of researchers and a huge team of programmers releasing it. That's going to come out this fall. It's called Lexi. It's a version, basically a complete remodeling of Intellix DNA. And so there are changes coming to Intellix DNA, but it's not about the price. It's about making it easier for clinicians to use it, prep, get an answer, and get ready for their consult.
Great. No, I think this will all, keep changing here in the future. But I did have a question that might be of interest also to our audience. So if we just talk about something like ApoE4, because it's one of the variants that a lot of us fixate on that see patients. And then on the other hand, something like MTHFR, which is probably one of the more over-interpreted variants. So two separate questions. With ApoE4, I know one of your questions after that is, well, is it a good ApoE4 or a bad ApoE4? So if you could say a few words on that and how the Intellix test sort of helps people differentiate that. And then with regards to MTHFR, how should a clinician think about it accurately without, dismissing it or, turning it into the cause for everything?
Absolutely. So with ApoE4, we always say ApoE4 is not enough or it's too much information. And by too much information, I mean, if you tell someone they're an ApoE4 and you don't tell them anything else about it, then they're going to think, gosh, I'm doomed. I'm going to get Alzheimer's. I'm at really high risk for Alzheimer's. But it's really not enough information because there are a lot of different gene variants that interact with it. Some of them, like there's one called BCHE, if you have ApoE4 with BCHE, it cuts your risk in half. But there's other gene variants that relate to the mitochondrial membranes. And if you've got, for example, 2 copies of ApoE4 and you've got this mitochondrial membrane problem, especially 2 copies of it, your risk could be 15 times the risk. But if you have 2 copies of ApoE4 and you don't have some of these interacting gene variants, and there's over 20 gene variants that interact with ApoE4 that have huge impact on the risk. So when I say huge, I'm not talking 8%, 10%. I'm talking 60%, 100%, really big effects, 50% at least. And knowing the whole pattern lets you help people. So I have an ApoE44 who is 82 years old and she's in the 95th percentile for cognition. But there are other ApoE44s that have a struggle that, and obviously she's done a lot to address her genomics as well. But partly why she is doing so well is partially because of what she's doing, because of knowing the other genomics with it, and partially because she didn't get all those bad genomics with it. So genes interact. So ApoE4 interacts with hormone genes, inflammatory genes, detox genes, mitochondrial membrane genes, other mitochondrial genes, BCHE, which is a butyrylcholinesterase, on and on and on. And that's what makes Intellix DNA different, is because when you have an ApoE4 who comes to you with cognitive decline that doesn't have BCHE, you've got to be looking for other clues, because chances are there's something else going on. And it might not even be Alzheimer's. It might be something that's causing more vascular dementia or brain ischemia, which means not enough oxygen to the brain, like things that make you have thicker blood, more clotting. It might be things that affect the myelin, the insulation. So that's why I say ApoE4, you can't use a tool that's going to give 3 cognition variants, 5 cognition variants, and get someone's cognition better. Intellix DNA is the genomics. For those of you who've heard of Dr. Bredesen, the end of Alzheimer's, and it's really his team, Dr. Kat Taupes and Christina Burke and Craig Tanio, and there's quite a few others. They have done a couple publications and studies, and we're the genomics they use in their studies to help guide how do we get this patient well. Of course, they also check for mold and different blood markers and such, but you have to have a genomics tool that's proven to work in cognition. Regard to your other question of MTHFR. So how did MTHFR become such the pop gene? Well, one copy is found in 40%. So is it easier to study a gene? So we have a publication on a gene that has huge implications in mental health that affects something called BH4. It's in 4%, 2 copies of it. Is it easier to study a gene where 2 copies is in 4%, or easier to study a gene where you can find a copy of it in 45% of the population? Obviously the first. So MTHFR was one of the first genes studied where it had a really big impact in mental health, because methylfolate is needed for making serotonin and norepinephrine and dopamine, which are all really important brain chemicals. But what I would say is it important to mental health? Absolutely. One copy, I kind of go, maybe you want to take some methylfolate so that you can support it, but know that you have to take methylfolate with riboflavin if it's one specific variant to get the full effect. But when you have 2 copies, it is a pretty important gene. 2 copies is about 13% of the population, and it can affect hearing loss in men. It can really affect mental health. It can affect things relating to fertility and birth defects. So it's an important gene. But like, for example, in our women's health report, which we didn't really talk about, which is about fertility and health optimization pre-pregnancy, we would never just give MTHFR. We have 400 different variants because there's so much that relates to having not first of all miscarrying and having successful pregnancy, but also then having healthy children in the next generation with proper brain development, neural tube development, et cetera.
Awesome.
Thank you.
So obviously there's so much depth to genomics, as you've been able to demonstrate. Question just came in about proteomics, right? And how do you think about, and I think that the general question is, how do you think about pairing other tests with genetics, right? I think you made a pretty strong case for why genetics should be a foundational test that we order, because it can be deterministic in what other tests might be useful and help us kind of narrow our focus. But curious to get your thoughts on proteomics, other complementary tests, and also added to that, if it's okay, where do you see this field going? Like, what are you paying attention to? What are you excited about?
Absolutely. So proteomics comes back to that issue of the only thing you can get from the blood are genes that are expressed in the blood. So proteomics is useful for the gene variants that are expressed in the blood in terms of as proteins, but it's just a small percentage of your genes. So you're gonna, there's things you can tell, but there's a lot that you can't tell. So remember, everything to do with neuroscience, autism, cognitive decline, depression, anxiety, ADHD, because of the blood-brain barrier, there's a lot of things expressed in the brain that aren't expressed in the blood. So that's the limitation of proteomics. And the same thing can be true for things going on in the bone or other tissues, but particularly the brain. The other thing about proteomics is, think about a woman's hormones, because it's a good example, because it's not just about hormones. You can have high levels of a hormone one week and low levels another week. Well, the proteins in your blood can change minute by minute, hour by hour. So it's a snapshot in time, whereas genomics gives you kind of a more solid foundational piece of information. That leads into the question of, where do I see the field of genomics going? So my co-founder and I, again, whenever you are a founder of a company, you're trying to solve a problem. What problem were we trying to solve? We're trying to solve the way medicine is practiced, because we feel like it's missing helping so many people. Most diseases are not due to one gene, so they don't have one way of addressing them. Diseases like sickle cell and cystic fibrosis that are truly genetic, yes, those have one gene. But everything that we as doctors deal with, pain, and we didn't even talk about pain and migraines and heart disease and diabetes and on and on and on, that people come to us, we need to have a bigger map. So for us, the goal is to move the field of science and medicine forward, so that a decade from now, when a psychiatrist has a patient come into their office complaining of depression, they'll go, let's get your genomics so we can get a map as to what's going on, so we can get a better treatment plan. When they have a cardiologist or someone coming into their office, they can have that same response. Okay, you have a family history of heart disease, but is it because you put more calcium in your arteries? Is it because of microclotting? Is it because of inflammation? There's two different inflammatory pathways that can give you 5 times the risk of heart disease and heart failure if you have both of them together. And let's understand what's going on, because then we can have a better prevention plan. And what we really are not good at in our American health system is prevention. And this genomics is the ultimate prevention tool. But also it also helps with untangling complex illness, chronic illness, and so much more. So our goal is that as a baby, as whatever age a parent's ready to have that information, whatever age an adult's ready to have that information, doctors are trained as to how to use that information, then help guide their patients to a truly precision approach to their health.
Yeah. It's definitely a worthy goal, and it will be interesting to track where this field is going in the next few years. To that point, we do have a question about the Intellex test and how it's implemented in different geographies. Are people worldwide able to do it? How does sending in the lab the swab testing work?
So we are what's called a clinical decision support tool, which means we give everything that a clinician needs to make better decisions. It allows us to give really lots of information, but it also limits us to only selling to licensed healthcare providers. So this is ordered by your physician. It can be nurse practitioner, MD, ND, DO, PA. There's a naturopath, licensed naturopath. So you would find, you can go to the Intellex DNA webpage. You can put in your region and find somebody who's licensed. We sell in the United States, Canada, and the UK right now is where we have the ability to sell. We do have a research affiliate in Australia. And you then can, your doctor either has it in their office or you get drop shipped to you a cheek swab. It's 20-second cheek swab on each cheek. Don't worry about mailing it back, even if you're in a hot climate. It's stable for years. You put it in this little vial, you stick it in the mail. About 3 weeks later, 3.5 weeks later, your doctor gets the results and goes over it with you. We help the doctor understand the results. We offer free training, free mentoring. The software can be organized into a hotspot. And as I said, it's going to get easier and easier to use. Can't wait to show you, Deepti, what's coming out soon. You're going to love it. Then they use it. And I always say, if you order the executive report or the powerhouse, which are, lots of information, don't go with it the attitude of tell me everything. Tell your doctor what you're concerned about, and also let them look and say, hey, this is what I want to talk about, because that's the most effective way. Sometimes just addressing the most important 5 gene variants can make a huge difference. So it's also about knowing how to use the results when they come back so that you don't kind of overwhelm yourself or the patient if you're a physician.
Yeah, awesome. I mean, you and I reviewed a few tests together, and I remember for at least two of the patients, you had mentioned that they should become gluten-free. And it's, based on like my history taking and based on even quite a few blood markers that we do. And I'm often able to see like, hey, I think even though you're not a clear celiac, which very few people are, there are signs and signals that maybe you should go gluten-free. But it actually has changed both of those patients' lives, even though there were so many other things on that report. But it's like small interventions are making big differences. And it's something that was picked up by this test only, that would not have been picked up otherwise.
And I'm not one of these people that tells everyone to go gluten-free. So if we were looking at it, then their genomics gave them 7 times the risk or 15 times the risk or really high risk. And it just happened to be the case. Because again, I think understanding each patient, and then they can try it and see how they feel. And that's really one of the fun things with genomics is all of a sudden we have a naturopath that improved someone's grade levels, 5 grade levels in 2 months of reading. Well, you would never be able to do that if you didn't know the underlying causes. And I don't want to promise that to everyone, or got a child from non-speaking to speaking or stopping seizures. So sometimes it's just having that insight can make such a difference. And somebody having pain that couldn't transport B12 to their brain and had hypercoagulability and gluten intolerance. Well, that's 3 things, and then their pain's gone. So again, there's a lot of different insights, and it's a super exciting field, as you can tell. But this is what keeps me from retiring in medicine is I have so much fun helping my colleagues understand what's going on with their patients and changing medicine. It's a great career to have, and I love doing it.
Awesome. Well, in 2026, I feel like we would be remiss if we did not ask a question that's somehow related to GLP-1s,
Mhm.
just because those are so topical, so relevant. They appear to be so promising from the standpoint of not just helping people improve metabolic health, but also increasingly improve longevity and healthy aging. So curious, how from where you sit on the genetics side, how is this intersecting with GLP-1s?
Yeah. So, did you know, and this will be in the Intellex DNA report by mid July, so very soon. It's already on things you're ordering there. We just have to make it show up. Did you know that 40% of the population will not lose weight in response to GLP-1s? And it has to do with a gene, a GLP-1 receptor gene variant. And the people whose blood sugar goes down the most are not the people who lose weight the most. The
Hmm.
good thing is the people who have the variant in the GLP-1 receptor that makes them respond better with weight loss tend to be heavier. So it's probably a little bit higher than 40% in your actual practice. But it's really important because GLP-1s are not inexpensive. So understanding who's going to be able to lose weight effectively, who not, is helpful. But it's also important to understand other things. Like one of the number one genes that contributes to obesity is STAT3. And when you have this grouping, again, Deepti was talking about groupings of SNPs compared to a single SNP of these STAT3 genes, if you eat high saturated fat, you get a logarithmic increase in your waist circumference. So just by telling these people to lower their saturated fat, which is things like butter and coconut oil and red meat, even the fat on chicken, those all fats that are
You
solid at
make a
room
lot of
temperature.
people upset on the internet by saying that, just so you
Well,
know.
but it's
I'm
for those
kidding.
people, it's not for everyone. But for
Yeah.
those people, lowering saturated fat and using more olive oil, nuts, seeds, plant oils can make a huge difference. So if they want to eat beef, I say, okay, but grass-fed beef has a lot less saturated fat than the average, and then certain cuts like I think a ribeye is much fattier than a sirloin. I don't eat a lot of beef, so I'm not quite sure. I think that's the case. So I think you can still give them the choice if they want to have to use other ways to control their weight and want to use GLP-1s, that's an independent decision. But at least they then have information. There's some people that like to do like keto diets, but if they have certain genetic effects that affect their mitochondria in certain pathways, they're going to feel sick on a keto diet and they need more carbs. So I do believe the era of precision medicine is here. Intellex DNA is working with a number of very knowledgeable individuals to add peptides into their report that we will be doing a launch of that this winter, this late fall or winter. I just spoke at a 1,700 person peptide conference, and I have a lot of colleagues now that are working with me on this. I had already had some and just expanded that, and it's going to be very exciting. It's because, of course, GLP-1s are peptides, and so we're working on. So there's certain pathways, a very common one that relates to diabetes, where GLP-1s work really, really well. But there's other pathways with diabetes where metformin really works better because it directly affects that gene. So I think that yes, genomics can help you understand how GLP-1s work. We're looking into some other things with it, but it also, there's variants that affect the nausea, that affect all these different things. And so knowing that can help you with dosing.
Yeah. I mean, I'm sure a bunch of people's ears just perked up when you mentioned peptides again. So what can you share there about how genetic testing can influence the better use of peptides? I think that's honestly I think we're all looking for smarter ways to use these. We
Yeah.
have these protocols, which are essentially just like oral tradition in a lot of ways. Like they were protocols that somebody at some point started guessing, and it seems to work. And, they do work to an extent, but I think we can be so much smarter in how we use these. I think we're going to learn a lot more. So what are your thoughts on that?
Yes, absolutely. So you can take peptides and you can know how they work on a genomic level and then pair them up. So we're expanding our genomics that directly relate to longevity, and there are genes that relate to telomere length. Well, epitalon is specific for people who tend to have the shorter telomeres. That affects telomere length. There are people who have elevated TNF alpha and increased risk for autoimmune disease. And there are certain peptides that are good for that. There are certain peptides that boost your immune system and are bad for autoimmune disease. There are peptides that work, like Humanin works on IL-17 alpha, but so does KPV. And so KPV, and again, sorry for people who are listening who were speaking a foreign language, but KPV, we knew that KPV could help gut stuff, and that's because IL-17 alpha also has a lot of gut stuff. But KPV can be very helpful to your autoimmune patients that have high IL-17 alpha because it's a direct way to lower IL-17 alpha. So again, it gives you this ability to kind of go, aha, and in kidney function, SS31, again, it works on certain pathways better than others. So for some people, for their kidneys, it's going to be great. There's a lot of things it can do with mitochondria and oxidative stress. But when you have it in the genomics and go, okay, this works specifically on this pathway. CLANC and CMAX can work on BDN. There's things that they can work on BDNF. They can work on certain psychiatric related pathways. So there's so many peptides. We already have quite a few of them mapped out. But again, we're waiting till this late fall or early winter to do our launch, because I have a team of peptide experts, and everyone in the field has been so kind to me that are all they're if they don't already use our genomics, they're learning our genomics. My team is studying the peptides more, and we are going to jointly launch this this winter. It'll start to slowly appear in the Intellex DNA report before that, but the formal launch will be late fall or early winter.
Great. Well, I think we're just about out of time. Anant, do you have anything else? Let me see if we have any other questions.
No, I mean, you've talked about GLP-1s, peptides. If you can touch on pickleball and AI, we'll have bingo. We'll be
we do have genes that relate to muscle endurance and strength. But as a pickleball player myself, I do understand the craze, because it's great for those of us who maybe have had shoulder injuries or a little bit not quite in our 20s anymore. It lets us get out there and have fun with our friends without having to have so much force. AI, again, I think the thing is, if you use AI, some of the tools out there right now, they're going to be using AI to use the same algorithms. And what Intellex DNA is going to do is going to be responsible use. Obviously, there's things from AI that can help where everything is still vetted, but let's use those tools instead to practice medicine in the way we want and make that faster.
Awesome.
Yeah,
and
that'd be great.
Just one last question from the audience, and then we can wrap. But so you mentioned earlier that Intellex is a clinical decision support tool. So how does this compare to other? And I know that you may not be able to comment on other companies, but how does this compare to maybe other genetic testing companies in terms of just the decision support?
Yeah, I think that that's a great thing. So most of the companies out there that you guys have heard of, and I don't want to name names because I don't want to, to call anyone out, but if a health coach can order it, if you can order it as direct to consumer, and again, health coaches are great, but there's just different laws. But if you can have it broadly ordered by people that are not licensed healthcare providers, it's not a clinical decision support tool, because that's one of the difference. That's going to limit. So you might get a gene, some genes that relate to diabetes, maybe even 3 or 4 on a report that has nutrigenomics in it. But they might have these general things like, oh, for diabetes, use a low glycemic index diet and maybe some berberine and maybe this. Whereas when you look at the Intellex DNA report, some of the gene variants relate to incretin, and we're going to talk about how whey protein and Gymneta sylvestre and GLP-1s all relate to incretin. Others relate to regulators that are specifically have interventions with more berberine and insulin resistance. Things that lower insulin resistance. Other genes can be specifically affected by metformin, and other genes that relate to diabetes specifically can be affected by exercise. But it goes even much deeper than that. You might have all these different inflammatory pathways. They all have different interventions. And so Intellex DNA allows us to do diet, lifestyle, supplements, even medications referenced, giving in the literature what is the dosing that's been used in the studies in the literature. So it's just a different, it's very different. Many reports that other genomic tools, there are ones that are pharmacogenomics. Pharmacogenomics is just how drugs are metabolized. It doesn't help you understand the root cause of the disease. So pharmacogenomics can be important of, do you need less Prozac or more? Do you, are you going to get, how are you going to respond to Wellbutrin in terms of, again, dosing because of your metabolism of the drugs? But what if the cause of your depression is endocannabinoid pathways and different nutrients and oxidative stress, et cetera, et cetera? It doesn't address that. And again, most of the other products out there are more focused on just the nutrigenomics. We are the only product I know that has panels that specifically go into the root causes of cognitive decline, the root causes of different mental health concerns of autism, PANDAS, PANS, even the level that we go into obesity and the level that we go into, things like fatigue and pain. We have more ability to help with on all those things. And so it's just a different tool. And if you're looking for Ancestry, if you're looking for rare genes, with Ancestry, there's one set of genomics tools. For rare genes, that's whole genomic sequencing. But if you're looking to be able to optimize longevity, decrease chronic illness, address chronic common illnesses, or even complex illnesses, that's where Intellex DNA was built for. That's who it was built for.
Yeah.
Awesome.
Okay.
Awesome. Well, thank you so much for joining us today. If people are interested in continuing to learn from you, is there a social account that you'd like to share? And if people are interested in reaching out to learn more about how they can incorporate Intellex or work with you in some way, what's the best way to reach out?
Well, on LinkedIn, they can follow us it's Intellex DNA. And you can also go to intellexdna.com, and it's 2 L's and 2 X's because it comes from an intelligent approach to DNA. And the 2 X's are myself and my co-founder are both women. They can go to Intellex DNA to learn more about how to find a clinician in their area. There's some videos there. There's some papers. We do have social media. I am so bad at, other than LinkedIn, I don't know like our Twitter and all that, but I bet it's Intellex DNA.
Well, thank you so much, Sharon. And thank you to everyone who was able to log on live and ask engaging questions too.
Thank you guys for joining us. Thanks for having me on Deep Deep.
Take care, everyone.